Thank you for participating in this lesson entitled Impact of Law on Professional Nursing. In this lesson, we will evaluate 3 case scenarios involving drug diversion, neglect, and supervision. These are the learning objectives. Identify the course of action one should take to initiate a drug diversion investigation. Recognize the role of advanced practice nurses and the responsibility they carry. And review the responsibilities of a nurse supervisor and recognize the responsibility they carry for both staff and patients. So this is the situation. A very experienced nurse ended up, there were some drugs that were missing from the Pyxis and she was blamed. The records did not match the count, so she was put on suspension and eventually terminated. She then took the issue to court and they found out a whole bunch of different things. Nurses testified and basically a lot of them didn't chart their narcotics until the end of their shift. So the count was maybe off more often than not. So what did the court do? Let's find out. Did the facility have sufficient evidence to suspend the nurse? Well, terminating one's employment is a serious matter, and the organization must ensure that questions are addressed prior to making that decision. Suspending an employee pending investigation is common and expected, but the nurse will either need to return and be cleared, return with corrective action, or be terminated. When investigating, do not automatically assume the worst. As a nursing director who has investigated many narcotic discrepancies in recent years, you need to assume benign intent first. It's far more likely that a clerical error was made as opposed to diversion. A nurse of 25 years, such as this lady, was well known amongst the staff and the management. So look at the education that was in her file. Have there been diversionary complaints or unsolved cases in her past? If the institution is unable to explain the discrepancy, it may be appropriate to contact the authorities so the DEA can get involved. They may choose to conduct their own investigation in conjunction with the organizations. Fraud should also be considered. The case study indicates that the RN uses a code to unlock the Pyxis. Are they certain that another nurse is not forging her code and taking drugs? The camera footage should be inspected during the assigned times of drug removal. I have instructed new orientees to remove the drug from the Pyxis and then show the drug to the camera prior to exiting the med room. Any added layer of protection to the nurse in the event of a discrepancy will help his or her case. Although diverted drugs may be sold on the street, many nurses with a drug problem will consume the meds themselves. If the organization did not offer a drug test, the nurse should seek an independent drug test the day after the suspension. Finally, consider interviewing the patients themselves. Can they report receiving their medications? Was pain well controlled during their stay? How did the nurse act? Those that divert drugs may struggle with a decline in appearance or behavioral changes. So the case study itself has many questions left for interpretation. How should coworker testimony affect the case? Testimony from staff nurses should absolutely play into the outcome of this case. Although the other nurses were not part of the diversion, their testimony shows how easily a clerical error can occur. Completing their narcotic documentation at the end of shift indicates a broader problem, whether that's time management, lack of education, or extreme patient loads. The court needs to understand why the nurses are doing this and why the nurse in question is practicing this way. Although the charts were off, the paper charts, the electronic record should allow the user to compare the administration record with the report generated by the Pyxis. Although paper charts are used, medications should either match or not match based on the electronic charting. Further, where did the complaint originate? Was it a staff member or a random audit from the pharmacy? The nursing staff should be able to articulate what steps they would take when they discover a medication error that's not accounted for. The ability to do this timely is paramount, as it makes it easier for the investigator to review the data and complete interviews. A common way for nurses to divert is through a wasting buddy. Does this nurse waste narcotics with the same person each shift? Other nurses may testify to provide more details. Another concerning aspect of practice that could result for discipline for everyone is the practice deviations described in the case when administering meds IV instead of subcutaneously. They were doing this, I think, because of lack of time. Changing the route of a medication can alter the dosage and potentially be fatal. It's evident that the nursing team has not had adequate education, or the facility has not established policies or procedures that are adequate to govern practice. This should lead the judge or jury to consider other means as to what went wrong with the missing medications. A lack of policy does not give the employee clear insight how to function and will not support termination if the policy can't be referenced. What questions should the hospital address before the court rules? So the type of drug that went missing is important to note. Is it a 50 milligram tramadol or a 20 milligram oxycodone? We don't know. I'd be much more inclined to suspect benign intent if a Schedule 4 drug went missing as opposed to a Schedule 1. Although the court does not add up, the count does not add up in the EMAR, we need to assume innocence first and then gather necessary evidence to prove guilt. Interviews should be obtained along with camera footage of the med room. Consider the nurse's background. Is this the first time this issue has come up, or is there a pattern? Have drugs gone missing over a 30-day period or a year? Multiple drugs going missing in a short time as opposed to a few over a long time may indicate clerical error. The nurse appears to have a strong work history with the company. She's been there 25 years, and she's a mentor that can help lead the group. The company should tread lightly on this one until they have all the facts. Nurses are indicating that charting is being done at the end of the shift when they may not even be aware of which drugs were given at that point. This is extremely dangerous and needs to be addressed immediately. Could patient workload be at unacceptable and unsafe ratios? The data may be indicating that. Finally, the hospital would find it in their best interest to investigate the IV meds that are being set up, altered, or distributed by the incorrect route. That would constitute unsafe practice and is board reportable. My final ruling, the nurse in this case should be allowed to keep her job as there was lack of evidence and overall investigation. It appears that there are several serious concerns this hospital needs to address. It may even be appropriate to report testimony to the regulators, as this scenario may trigger an immediate jeopardy for the hospital. Policy and procedure needs to be developed and strengthened, and elimination of the paper charts may assist with this. Just a few more tips on conducting a thorough investigation. This was written by a board member from the North Carolina Board of Nursing. So as a nursing director, I've conducted countless investigations myself. When a drug goes missing, first examine the EMAR versus the paper chart versus the pill card or the bottle. Many times a nurse forgot to sign a medication out, giving the illusion that it was not given. If pill cards are used, nurses may find it beneficial to sign their name next to the medication that was removed. If this does not clear things up, search the unit, the cart, the med room, the patient room. Sometimes medications fall onto the floor and we may not even realize it. Next, interview employee and staff members to find logical explanations. Sometimes 2 narcotics may have been given instead of just the one that was prescribed. It's much easier to write up a medication error instead of doing a discrepancy report or a police report. And then consider the drug schedule in question. There's a low likelihood of diversion if a 50 milligram tramadol goes missing, as opposed to a 20 milligram of Oxycontin. If no plausible explanation can be found, contact the police so they can conduct their own investigation. Sometimes the DEA even needs to get involved. If drug diversion is suspected, there are many methods which this could occur. So substitution and dilution, manipulation of records, prescription forgery, failure to document. and inaccurate waste records. Remember that a discrepancy is always a number. It's not poor handwriting or time errors. Always collect statements from both the nurse being suspected of diversion and the nurses on the unit. Has the nurse been acting differently? Are there any new patterns? Also, always be direct and ask the nurse if he or she took the medication that was missing. Don't beat around the bush. Case study 2 looks at appropriate treatment. So just take a moment to look at what's on the S bar. So in this case, a patient went to the clinic because he had diarrhea, and the nurse practitioner prescribed an antibiotic, but before she did that, she consulted with the MD. Unfortunately, a couple days later, he died of a heart attack. Was the heart attack related to the GI issue? Should the GI issue been examined further? There weren't any labs done. Was the appropriate standard of care met? How should the defense suggest the standard of care was met? So although the prosecution may have a stronger defense, as I'll point out later, the defense can argue several points. Nurse practitioners in many states are allowed to practice independently, while some must practice under a physician. Assuming this is a state where an NP can function independently, he or she may have gone above the standard of care by consulting a physician on the symptoms. Further, this was a set of symptoms that was in the scope of practice for an NP to diagnose and treat. GI upset with possible infection can be successfully evaluated and treated by a skilled NP. Has the NP seen the patient before? If he or she knows the patient's history, that could provide a clearer picture of what's going on given the medical history and the risk factors. Assuming this is the case, that could be used by the defense. Further, was patient education conducted? Knowing what to monitor and contact the clinic for after discharge is important. Many patients may not be fully honest when going to the doctor for a variety of reasons. Although this could be seen as negligence, perhaps the NP was only given a series of symptoms that appeared benign, but upon further review would actually be serious. This is where charting by the medical team becomes more important than anything. In this case, after the patient died, an autopsy was not conducted. So does not having a full autopsy affect the case? Having an autopsy would add additional power to the prosecution. Not having an autopsy can only assist the defense. Hypertension is listed as a contributing factor, but how can the team prove a link between the GI pain and a myocardial infarction if there's no autopsy? Certainly hypertension alone would not have triggered this much discomfort, but hypertension should have been identified at the clinic visit, as vital signs are always taken. Further, would an infection of the GI tract lead to a heart attack? Likely not, unless the patient went septic, and that would lead to a broader set of systemic symptoms affecting the heart. Unfortunately, other diagnostics were not performed that day. As explained in the next slide, it's difficult for a provider to know if the care being given is appropriate, if the true cause is not evident. In this case, it's a presumed infection. Consider interactions that could occur with Flagyl, that was the antibiotic prescribed. Alcohol and cold medicines can cause severe side effects. Unfortunately, the list of side effects associated with Flagyl is long and tedious. The prosecution will be unable to rule out encephalopathy or liver problems caused by Flagyl because there was no lab draw. Would a more thorough exam have changed the outcome of this case? A more thorough exam is necessary to determine the root cause of the symptoms. Due to antibiotic resistance, the standard to evaluate and prescribe has been evolving in recent years. So an individual with a GI infection should really have a GI panel done, which would check for a multitude of enteric pathogens, including C. diff. C. diff infection is not treated with Flagyl, it's treated with vancomycin. A blood test should have been conducted to verify kidney function and dosing of the vanco. In the case of this patient, how are we sure that an infectious disease is prominent without diagnostic testing? How can we ensure that treatment is appropriate without testing? Many diseases share similar symptoms, so obtaining samples of bodily fluid like blood or urine or spinal fluid can help tailor treatment to the patient's needs. Based on the listed cause of death, it may have been beneficial to conduct a complete blood cell count, basic metabolic panel, as the prosecution suggested, and even cardiac markers, as cardiac symptoms can mimic GI symptoms from time to time. I also share concern with the duration of the antibiotics prescribed. Many antibiotic courses are running 7 to 10 days, sometimes less. If the patient was told to continue taking antibiotics on day 9, how long was the antibiotic course prescribed? A follow-up exam may have changed the outcome for the patient. The list of potential side effects for Flagyl include dizziness, heartburn, stomach cramps, so blood tests could be used to check for liver damage. Although the prosecution indicated Flagyl can enhance diarrhea, funny as it is, constipation can also be a side effect. So how should the court decide? Although there is a strong correlation, it cannot be proven that the patient died of causes related to the actions of the NP. I don't believe the NP held to an adequate standard of care, as she failed to initiate diagnostic testing to determine if infection was present, and if so, how to treat it. The NP's notes are worth a lot in this case in determining what her thoughts were and what the patient indicated during the visit. An autopsy could have changed the outcome completely, as cause of death would be identified, which would have given the prosecution better leverage. In another way, an autopsy could benefit the defense as well. Perhaps the cause of death had nothing to do with the illness he had. Perhaps he suffered from a GI infection, but it was well controlled, treated with Flagyl, and the heart attack that followed was already bound to happen. We cannot be clear as there was no autopsy. In this case, I'd rule in favor of the defendant. Our last case study is in this S-bar. Situation was a surgical patient developed fatal septicemia and died. Patient went under a hip surgery and developed fevers post-operative. The LPN did tell the RN manager that something wasn't right, but the RN only gave Tylenol, but the fever kept rising. So the question is the supervisor just as liable as the nurse assigned to the patient's care? The answer is yes. The RN should have evaluated and called the doctor earlier, but that did not happen. But how will the court rule? Let's find out. The nurse did have responsibility to supervise and even evaluate the care of the patient. Nurses are viewed as an extension of their supervisor. This is known as vicarious liability. To break the word down, a victor is one who substitutes function for another person. All acts that are done by a servant are done by the master's implied authority. Therefore, all acts of the nurse are then the master or the nurse supervisor is responsible. It's expected in nursing that supervisors are held to a higher standard and have an extensive degree of knowledge and understanding of the patients and the staff that are under them. The knew or should have known doctrine applies here as well. The LPN expressed her concern regarding the fever, but was still encouraged to mask the symptoms with Tylenol. With the patient's fever breaking 102 Fahrenheit, that should have warranted an evaluation by the RN and a notification of the doctor. Usually a fever of 100.4 should automatically trigger a call to the doctor. Also, the supervisor is tasked with ensuring that the staff are competent. If they're not competent, the supervisor needs to conduct education. It may have been the supervisor that needed education. Who knows? Was the care appropriately assigned to the LPN by the charge? Care may not have been appropriately assigned. Float team members are unfamiliar with the units and the patients that they go to. It is common to assign the patients with less acuity to the team members that are floating. That helps to ensure safer outcomes. If staff are arriving from a travel agency, there is minimal understanding of the hospital's policies or procedures, and the degree of competence has yet to be determined by the team. Likewise, it is surprising to see an LPN taking on the care of a patient in a hospital setting. An LPN's scope is reduced to focused assessments rather than full patient assessments that the RN could conduct. A patient just coming out of surgery will need extensive monitoring, which is what an LPN may not be able to do. If the charge assigned the care to the LPN, did she retain supervisor responsibility that would result in liability? Yes. The charge nurse or house supervisor retains responsibility of all patients, but liability increases further liability decreases for the supervisor and everyone else when communication is clear and concise. In this case, the LPN updated the charge nurse with the patient's temp, which should have resulted in increased monitoring by the charge nurse. Both the LPN and the RN have advocacy roles for their patients. If the LPN did not feel care was appropriate, she should have felt inclined to escalate the issue to the on-call physician herself without facing retaliation. When the patient experienced a fever of 102, a full head-to-toe assessment was necessary to determine the extent of the illness. The RN was obligated to check the wound for signs of infection, along with a possible UTI, DVT, pneumonia, interaction with other drugs. Further, the house supervisor has a role to maintain safety. These areas of safety include staffing, patient flow, and crisis management. Although many hospitals set up their supervisory roles differently, someone is always in charge, and the nurses need to communicate up the chain of command when a patient's status changes. Some settings, such as long-term care, do not have a nurse acting solely as supervisor. Rather, the supervisor may have a patient load and also has to juggle two tasks. Either way, someone is always in charge and needs to ensure that the nurses have support and direction. Therefore, the RN does have supervisor responsibility that could result in liability. How do principles of delegation and supervision figure into this case? Supervision is an act of directing, guiding, and affecting the outcome. The LPN retained the assignment and carried out the essential duties because the supervisor believed that she was competent. A supervisor should then have guided the outcome better by assessing and calling the physician earlier in the evening instead of waiting. Delegating is the act of assigning pieces of the nursing process to staff, but not the parts that require critical thinking. It involves authority and accountability on behalf of the nurse. Delegating does not transfer the ultimate responsibility of the outcome away from the nurse doing the delegating. The RN is still responsible. In this case, the LPN had an assignment and the task of giving care was not delegated. What complicates matters is that the supervisor would have needed to do a full and comprehensive assessment. Therefore, a piece of delegation would have been present in this case, as the LPN technically cannot complete the entire nursing process. To look at liability further, consider the education that the RN has on file. Has the RN been trained on what to look for if an infection is present? Does the RN know what temperature triggers an MD notification? These factors could prove negligence as opposed to just being oblivious. So how would I decide this case? This patient's death could have been prevented if measures were taken to address the infection. Although it's normal to have a temperature after surgery due to increased inflammation, a persistently high fever that remains high, even with antipyretics, is a concern that should have been addressed months earlier. A fever is classified as anything 2 degrees Fahrenheit or above baseline. Once a fever was detected, the on-call provider should have been updated with relevant information like the vital signs, incision, site. The worst that could happen is the provider would have instructed the team to continue the same course of treatment. Nurses need to act as advocates. The RN should have advocated by calling the provider. The LPN could have advocated by continuing to press onto the RN the change in the patient's status. Conclusion: narcotic discrepancies are common, but nurses can take measures to reduce the liability. Advanced practice nurses are held to a high standard, but in many cases, they're held to the same standard as physicians. And supervisors are fully accountable for the activity occurring under them. Employees are an extension of them, and the supervisor must ensure all staff are trained and competent. These are the references. Thank you for listening.